Thank you so much, Professor Perlapelia, and also Professor Simon Daniskova for the previous presentations. And they are very, very nice. And of course, we are all friends and colleagues in the FDI and met you in Sydney and various other places. And we continue to continue our friendship. And although I am yet to see Professor Marion, and hopefully we'll see you soon. And yeah, so as I said at the very beginning, I would, it's my great honor and, it's a delightful thing, delightful to open this presentation of the InnoBioDent part, second 2.0, which is a brainchild of Professor Marion, which is I think it is really credible that he got this idea, and because all of us are going towards green dentistry, and that is a trend for all the other specializations, and also which was mentioned very clearly by Dr. Paula and Dr. Simona, that body, we have to bring the body and the mouth together, and then it's important that we consider this as a holistic holistic venture. So without further ado, as I mentioned earlier, I'm going to talk about green dentistry, and let me green antibiotics, and let me share my screen with you. So this is my presentation, the title of my presentation. So once again, good morning, good afternoon, good evening. And I know this is live streamed, but also it will be in the YouTube. Now, I'm going to talk to you about the contemporary perspectives in green antibiotic therapy in dentistry. And this is a very, very topical subject because both medical practitioners and dental practitioners have to be aware of the proper antibiotic therapy. And as you will see, I will be introducing various concepts such as antibiotic stewardships and the rationale for antibiotic prescriptions, and how we have to not to stick to the traditional ways of antibiotic prescribing and have this so-called green antibiotic therapy as we are running out of antibiotics in the world. So with these opening remarks, let me just take you through some of the my earlier the preamble of this session. Now, the first antibiotic was discovered in 1928 by Sir Alexander Fleming, and of course, all of you know that he discovered penicillin, and then after his discovery, and which really saved millions of lives, particularly after the Second World War, through preventing wound infections and treating wound infections. And 7 years later, that's in 1935, he said this. He said the microbes are educated to resist penicillin, and a host of penicillin fast organisms are bred out. In such cases, the thoughtless person playing with penicillin is morally responsible for the death of the man who finally succumbs to infection with the penicillin-resistant organism. And I hope this evil can be averted. So he had the prescience to realize that penicillin are going to be, the usefulness of penicillin going to be running out pretty soon, because there are going to be penicillin resistant organisms. And here we are seeing today the effect of the wide prescription of penicillin all over the world. And I have to just say that he was the first to touch on what we today refer to as antibiotic stewardship. And then just to give a little bit more background, the World Health Organization has declared that antimicrobial resistance is one of the top 10 global public health threats facing humanity. So here's the importance of dentists being aware of this threat and how we can avert this threat, and that is very, very critical. So if you look at the global scenario, an estimated 1.2 million people died from antibiotic-resistant bacterial infections. So antibiotic resistance is so wide. You can see here the dark red areas. There are so many people dying of antibiotic resistance. Then dark red and like mauve areas. And one reason for this is because of the willy-nilly, or as we say, prescribing antibiotics without any rationale, and thereby abusing antibiotic usage, and then giving strong antibiotics when less strong antibiotics such as penicillins are effective. So we have to be very careful in this context in terms of antibiotic prescribing in dentistry, and that's what we are going to talk about in this presentation. Now, also, it has been predicted by the World Health Organization that antimicrobial resistance by 2050 is going to be something like this, even in places like America and Europe. Not only in Africa, but other places, people are going to die of antibiotic resistant bacteria. For example, if you take Staphylococcus aureus, and if you get systemic infections with a variant called vancomycin resistant Staph aureus called the VRSA, and this VRSA is actually if this Staph aureus, this particular strain or species, is resistant to all the antibiotics, and the vancomycin is the most strongest antibiotic we have for staphylococci, and if they are vancomycin resistant, that means there's no other antibiotic useful for that particular patient. So similarly, there's going to be a lot of antibiotics which are resistant to all the available drugs today, and as I will show later, I will tell you some of the reasons why we are running out of these antibiotics. Then the other thing I have to mention is that just like the spread of diseases like COVID and then HIV, and these antibiotic resistant organisms go from one place to another very, very quickly, because we have got rapid transportation system. Somebody in Hong Kong today can go to USA tomorrow and take the antibiotic resistant organism there. So a resistant threat anywhere can quickly become a threat at home. So this is a very important message we have to realize. And these are data from the United States Centers for Disease Control. So having that preamble, I will just share with you the outline of my presentation. And this is, I'm going to talk about some of these issues in the next 45 minutes or so. So the general issues of antimicrobial chemotherapy, the people who prescribe antibiotics today, is it not only doctors, but as you will see, there are other personnel who prescribe antibiotics in addition to doctors and dentists. Then factors influencing prescriptions, then reasons for the emergence of drug resistance. And then I'm going to talk to you about a new approach, a relatively new approach, which we call the One Health approach, which is very important to realize that we are all together in this world, together with the environment and the antibiotics and the animals and the bacteria and fungi and humans. We are living in this ecosystem, and we share this ecosystem. And this is the basis behind the theory of the One Health approach. Then we have a thing called antibiotic stewardship. I will tell you what it is and the steps we as dentists can take in terms of the antibiotic stewardship implementation in our practice. And then I'm going to talk about the so-called 6 Ds of drug prescribing, and then finally get on to the American Dental Association guideline on antibiotic prescriptions and some take-home messages. Okay, so that's the outline of my presentation. And let me just talk you through the general issues with current antibiotic therapy. And as I mentioned earlier, the emergence of antibiotic-resistant organism is a catastrophic threat of global concern, according to the World Health Organization, and one of the top 10 concerns in the world. And why is this the case? This is because the extremely slow discovery of new antimicrobials. Now, in the 50s, 60s, and 70s, there was a lot of new antimicrobials developed because at that time there were no stringent requirements for testing antibiotics on humans. And now, however, there are these stringent requirements leading to massive research and development costs of companies, and then therefore difficulties in conducting extensive clinical trials. As you know, there are phase 1, phase 2, and phase 3 clinical trials, and these have to be all conducted and fulfilled before an antibiotic or antifungal agent is allowed by the authorities such as Center for Disease Control and Food and Drugs Administration in US and various other parts of the world. And then, of course, people are very, very scared to, put into the environment a very new antibiotic which has not been properly tested, because the society is very litigious in the sense that they will for the slightest thing they will say the new antibiotic created this illness, and then the antibiotic, the manufacturers have to pay millions of dollars as compensation for these individuals. So these are some of the reasons why new antibiotics are not available as much as before. So we have only very, very few new antibiotics or antifungal agents. So then some of the other general issues are antibiotics account for the vast majority of medicines prescribed by dentists. In dentistry, we do prescribe a large majority of drugs, including antibiotics. And for example, in the UK, these are the statistics available, particularly in UK. I don't know about other parts of the Europe. And it has been estimated that 7 to 11% of all common antibiotics are community prescriptions of all antibiotics, and then UK dentists prescribe these. So we prescribe a substantial proportion of antibiotics in the UK, and I believe this is the same in all parts of the world. But the UK is a society. UK antibiotic prescribing is very, very highly controlled. Even then, if something like 10% of the antibiotics prescribed are by dentists, but I believe in other parts of the world where there's not so much control, and antibiotics may be prescribed by dentists, much larger percentage of antibiotics may be prescribed by dentists. So, and also it has been estimated that 1/3 of all outpatient antibiotics are unnecessary. Not only in UK, but all the other parts of the world, because they are prescribed for general flus and they are not prescribed properly, as I will show you in a moment. So dentists therefore must be acutely aware of the contemporary principles of antimicrobial, rational antimicrobial therapy. And I will describe and define that word in a moment. So then who else prescribes antibiotics, and how do antibiotics get into the environment? And so apart from the medical and dental practitioners, we have the nurse practitioners, veterinary practitioners who treat animals, do prescribe antibiotics a lot. And then the maximum amount of antibiotics are prescribed, are given in farming and beg your pardon, poultry industry. So they say over 60,000 tons of antibiotics prescribed per year worldwide. And this is given to fatten the animals and to make them free of any infections, and thereby they get more mileage or more meat out of these animals like pigs and chicken and so on and so forth. So dental practitioners at the bottom here say approximately 10 to 15% of overall prescription. So these are the people who prescribe antibiotics, and not only doctors and dentists. So there are other groups of personnel, professionals who prescribe antibiotics, and they all come into the general ecosystem, and then they are exposed to various bacteria and fungi, and they then develop antibiotic resistance. So a little bit more about the agriculture and aquaculture use of antibiotics. So you can see here, more than 28 million pounds of antibiotics are approximately utilized. So 80%, three-fourths of antibiotics annually consumed, sorry, 4/5 of the antibiotics annually consumed in the United States used within agriculture and aquaculture. So this is to, of course, as I said, to enhance the growth of animals and, fish and chicken and so on, and not to combat disease. If you look at this slide here, so this is antibiotic prescription per provider roll from 2011 to 2014. These are a little bit old data, but you can see dentists are in the brown, line over at the bottom. But even during that time, the numbers are increasing. I derived this graph from the Centers for Disease Control and Prevention. A little bit old data, but just shows the trends in terms of antibiotic prescriptions. Whereas the primary care physicians, the trend seems to be coming down here with regards to nurse practitioners and dentists. This seems to be going up. This is the latest data I could find. I hope we can have more recent data on this very soon. Then what is the impact of the COVID-19 on antibiotic prescriptions? And this is actually a very interesting article in the British Dental Journal. How did COVID-19 impact on dental antibiotics across England? And you can see here the red line. This is during particularly in 2020, when the COVID infection was at its peak, was flattening out virtually at its peak. You can see the red line, how antibiotics increased, prescriptions increased in UK. So among dentists, this is, and the reasons are very speculative, and people think because the patients could not go to the dentist, and usually you get teledentistry, and they phone, and then for the slightest thing, if there's a swelling or inflammation, the dentist would tend to say take some antibiotics. So that may be the reason, but this is purely speculative. So what are the factors influencing healthcare professionals' prescriptions of antibiotics? So they can be divided into three major groups: healthcare workers' perceptions and practices, patients' perceptions and beliefs, and some of the contextual factors. So here the healthcare worker or the dentist is involved. Then the next one is the patient and some contextual factors. So let me explore these three particular items and take you through this. So what are the healthcare workers' prescriptions depend on so many different factors. So it has to be the presence of an infection, severity of the condition, availability and cost of the medication, dosing and the duration, either appropriate or inappropriate. Prophylaxis, virtually most of the prophylaxis these days are inappropriate because prophylactic antibiotics, even for cardiac issues, are given very, very rarely, only in exceptional circumstances. Then giving antibiotics for viral infections and trivial infections. So all these actually, some of these are legitimate ways in which antibiotics should be prescribed, and some of them are actually absolutely useless. The antibiotics actually acting as more as a placebo than anything else. And then let's get on to the patient factors, which are also equally important. Now, when a patient comes into a clinic, the dental or medical clinic, we have to say that the patient's demands have to be sometimes met, because otherwise they are unhappy and they may not come back to your clinic if they are unhappy. So sometimes people, the practitioners, tend to look at the patient's perception. Of course, patient is the individual, he is taking the antibiotic, and it's very, very important that the patients, you pay heed to the patient's wishes, and if it is not correct, then you have to explain very carefully why antibiotics are not necessary. So patient factors include demand for the popular antibiotic, inability to. So sometimes the patients come and ask, doctor, that I would like to have this antibiotic, because last time you cured me with this and I would like to have this again. So what do you say? Then also, if you prescribe expensive antibiotic, they say, no, I cannot afford it, so you'll have to give me a lesser expensive drug. So, and also they are very ignorant about antibiotic abuse and antimicrobial resistance, and you will have to educate them on that as well. There is also ignorance of the long-term implications of antibiotic abuse. And then a lot of people think that they are allergic to antibiotics. So in the next slide, I'll talk to you about this allergy business. So this is a note on penicillin allergy. It has been found that 70 to 90% of patients who gave a history of penicillin allergy could actually tolerate penicillin. So these are their imaginations, or sometimes they think they are allergic to something else, therefore they should be allergic to penicillins or various other antibiotics. So less than 15% of patients with penicillin allergy are still allergic 10 years after their last reaction. And then thirdly, unnecessary avoidance of penicillin in patients who are not actually allergic will result in extra cost and overuse of drugs that should be reserved for treating drug-resistant organisms such as vancomycin. So some penicillin drugs are commonly associated with drug rashes, and although they cause rashes, these reactions are usually mild, and this doesn't really cause major problems to the patient, and it results in patient dissatisfaction. So this allergy issue is something which we have to be aware of it. But of course, the patients insist that he or she is allergic, then you will have to then do an allergy test, I suppose, but we don't have the facilities in the dental surgery to do that. And the third thing we are talking about, I said there were three things in relation to factors influencing healthcare. And first is healthcare worker itself, the second is patient, and the third one is the contextual factors. So what are these contextual factors? These contextual factors are depending on which country, which region, and which geographic jurisdiction you are working. You have overburdened healthcare systems, then there is not enough antibiotics. You have to resort to the only available antibiotics that may or may not work. So that is a kind of antibiotic abuse. Then influence of the big pharma. The older days, the big pharmacological societies or companies rather, they used to virtually bribe doctors to give their new antibiotics to the patients. But this is now being curbed by a lot of agencies, and there are very strict regulations in this regards, and it's very, very difficult to do that. But the pharma influence of the pharma is very, very high. Then with regard to time constraints, and also if you want to do antibiotic sensitivity testing, absence of these testing services is another factor. And then other factor is the fear of litigation. The doctor, uh, if he thinks that the patient may file a case because the patient got worse because the doctor didn't give antibiotic, in order to cover himself or herself, the doctor usually use an antibiotic just to cover himself. So this is also another major issue which we have to face in the very litigious society we are living in. So next, so we have covered here the general issues of antimicrobial therapy, who prescribes antibiotics, and factors influencing prescriptions. Let's talk about the reasons for emergence of drug resistance. So there are antimicrobial. There are a number of reasons for emergence of drug resistance. And then there was this group of experts assembled by the President of the United States and some years ago, and he assembled these experts from the Institute of Medicine and asked them to find out why there was antibiotic resistance emerge. And they actually, that's a big report, and there were three major areas which in relation to that, and that is healthcare, environmental changes, and microbial adaptation. So I will just take you through these three areas. So why you get these resistant organisms AMR developing is the presence of new medical devices and organ and tissue transplantations, and these patients are live for a longer period of time with all these tubes and insertions which get colonized by antibiotic resistant organisms in these patients, and they spread around, and together with immunosuppression and lead to antibiotic abuse. Secondly, you have the environmental changes which we are facing today, such as deforestation, floods and droughts, and global warming. These are things which are very, very critical for the spread of antimicrobial resistant organisms, and we are seeing this as we speak all over the world. And then of course we have the wars and different things like refugees, and we can see this now happening in the Middle East with lots of refugee populations without proper health care. And then if you get antibiotic resistant organisms in that situation, then they start spreading all over the world, and all over that area, and also spreads to the other parts of the world as well. Then the microbes themselves are very, very smart. They are always one step ahead of us, and they have their when they emerge from the wild, like from the jungles, like in HIV situation, then like also from so-called COVID-19s, they are supposed to have come from bats, and when they emerge, then they create lots of new organisms which are antibiotic resistant, and they also change in their virulence and toxin production. And then of course they from one generation to another, there is development of drug resistance. So these are very, 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 very in short. I mean, you can have one lecture on this emergence of drug resistance, but the major reasons why the Institute of Medicine said that the antibiotic resistant organisms emerge in the current day and age. Now, again, talking about, I mentioned that these the antibiotic resistant organisms emerge from coming from the forest, like bats and rats and monkeys, causing things like HIV and COVID-19, and happening new bacteria and new organisms and new viruses which are resistant to either antimicrobials or antivirals. That just shows that we are living in a single ecosystem where we interact with animals and the ecosystem and the humans all together. And this new concept is called the One Health approach. And this is developed in 2012 in Davos, in Switzerland. And it is the new concept. One Health approach is a so-called integrated unifying approach that aims to sustainably balance and optimize the health of people, animals, and ecosystems. So there are three major players here: people, animals, and the ecosystems. So it's important to recognize, according to the new concept, that human health, domestic and wild animal plants, and the wider environment, including the ecosystems, are closely linked, and we are all interdependent. We depend on each other. And we know that, the global warming causing various droughts, and then hunger, and people dying of, crop failure, and so on and so forth. So I don't want to go into that area. But this concept is very, very clearly illustrated in this next one, which is the this is why here you can see the animals and the humans and the whole ecosystem coordinating and communicating and collaborating to create this One Health system. So here we see people who protect humans, animals, and environmental health and other partners. And then the One Health system helps us to achieve the best health outcomes for people, animal, plants, and our environment. So the concept of One Health is a collaborative, multi-sectoral, and transdisciplinary approach, working at the local, regional, national, and global levels, with the goal of achieving optimal health outcomes, recognizing an interconnection between peoples, animals, plants, and their shared environment. So if you have not heard of this before, I hope you will, this is the first time you heard of this. This is very, very important concept which governs, antibiotic resistance as well as average healthcare of everybody, oral as well as systemic healthcare. So this was adopted by the World Health Organization for supporting and capacity building, which is important for those who are involved in capacity building in health systems, and also combating emerging epidemics and combating neglected diseases. And then it, of course, extends to food safety and environmental pollution. And, of course, antimicrobial resistance is also one of the including conditions here. So this is a relatively new One Health concept. So again, this kind of diagram, I mean, if you go to the internet, you can see hundreds of items on these articles. And so as you see here, antibiotic resistance is a One Health problem. The health of people is connected to the health of animals and the environment. So it's all interconnected. So what are our obligations as dental health professionals in promoting One Health and mitigating antimicrobial resistance? And this is where the concept of antibiotic stewardship comes in. I believe it is not very, very new, but it's been there around for some time. But actually, it's coming into the fore because of the antibiotic resistance issues. So the antibiotic stewardship concept, is a coordinated interventions designed to improve and measure the appropriate use of antimicrobial agents by promoting the selection of the optimal antimicrobial drug regimen. Okay, so so the antibiotic stewardship is an effort to measure and improve how antibiotics prescribed by clinicians and used by patients. Improving antibiotic prescribing and use is critical to effectively treat infections, as we know, and protect patients from harms caused by unnecessary antibiotic use and conduct antibiotic resistance. So we as dental practitioners, when prescribing antibiotics, have to look at these particular issues. Is there an infective etiology? Have relevant specimens been taken before treatment? For example, in the case of dentoalveolar abscesses and so on, and also chronic infections like actinomycosis, which are, of course, rare, we'll have to look at these things. So when should the treatment start? And then finally, last but not the least, which antimicrobial agent has to be used? So these are the 4 important core areas which we have to look at when we are prescribing an antimicrobial. So if you break down these core areas, is there an infective etiology? So when there's no good clinical evidence of infection, antimicrobial therapy is unnecessary, as we all know, except in prophylactic situations. And as I will, I don't have too much time to go into antibiotic prophylaxis in dentistry, but the number of situations where we give prophylactic antibiotics is becoming less and less. For example, third molar surgery, people used to routinely give antibiotics as a measure to prevent infection, post-operative infection, but that has been prescribed for a long period. And similarly, antimicrobial prophylaxis for people who are having suspect of infective endocarditis or cardiac issues. Again, the number of prophylactic instances where prophylaxis is given has been reduced to very situations where it's quite rare actually, but I don't have time to go into this. Please look at this. So the next question is, have relevant specimen been taken before treatment? Because if you start treating before taking the pus or any other specimen from the patient, that means the antibiotic, you will not get the antibiotic resistance of the organisms, antibiotic sensitivity patterns, proper antibiotic sensitivity patterns of the causative agents. So therefore, appropriate specimens should be collected before drug therapy, and earlier the specimens are taken, more likely the results will be useful for patient management. So these are the first 2 things. So the other principles of therapy. So as you all know, and all antimicrobials demonstrate selective toxicity. And in terms of prescribing antibiotics, it can be sort of 2 ways. It could be dichotomous. So we call the rational antimicrobial therapy or empirical antimicrobial therapy. So the rational antimicrobial therapy is usually described by doctors when they know the antimicrobial sensitivity of a specific organism, such as staphylococcus or any other organism causing the infection. And then treat the infections depending on the causative organisms and the sensitivity of that causative organisms for the antibiotic. Then the empirical antibiotic therapy is prescription of a drug on a best guess basis. And actually this is what we do in the most dental practices, because number one, we don't have situations where we could take good samples because of the oral cavity contamination. Number two is because we don't have, lots of places don't have antibiotic testing services, and also it is more costly and you have to wait for a few days, sometimes few days, before the antibiotic sensitivity reports come in. So hence, for these reasons, in dentistry, we do empirical antibiotic therapy on a best case basis on our previous experience of prescribing antibiotics for specific conditions, such as pericoronitis, which is very, very acute, where the patients cannot open their mouth, or you cannot drain the drain the abscess, or such as Ludwig's angina or conditions like that. So, and empirical antibiotic therapy in dentistry, we give the antibiotic depending on the most probable pathogen from our previous experience and the known antibiotic sensitivity pattern of the pathogen in the region or the country. So, as you all know, just some antibiotics do not work in some countries because of wide antibiotic resistance of that organism in that part of that geographic region. So you have to be aware of the antibiotic resistance in a specific area. So what are the instances where we do rational antibiotic therapy? Fever and acute infection, spreading infection without localization, chronic infection despite drainage and debridement, infection in medically compromised patients, and cases of osteomyelitis, bacterial sinusitis, and some periodontal diseases such as AUG and localized periodontitis. So in these cases, it is really appropriate to take not to do empirical antibiotic therapy and do rational antibiotic therapy, because we have to know better to know the causative agent rather than going in blindly and giving a very broad spectrum antibiotics, which may not cure the condition, and it may even make the condition worse. So these are some of the therapeutic guidelines for dentistry, which is in basic textbooks, but I thought this is a good opportunity to revamp, just to share with you the basic knowledge in this context. So we are coming on to the sort of last few slides of this antibiotic rational green antibiotic therapy. First, we will go on to the 6 Ds of drug prescribing. So what are these 6 Ds of antibiotic stewardship? So as you can see here, you can see 6 Ds. So diagnosis of the condition, the drug which you are prescribing, the dosage is very, very important, the duration is important, and then when to stop the drug. So that is called de-escalation of therapy. And last but not the least, debridement. So it's useless to give antibiotic if you do not clean up a specific wound, or if you do not drain a pus of that site, of the infected site. So these are the 6 Ds of antibiotic stewardships. So let's take this. So you can see this here in this diagram here: diagnosis, drug, dose, duration, de-escalation, drainage. So we have the diagnosis. As I said, you'll have to make a good diagnosis, make an accurate diagnosis, either bacterial or viral infection. As you all know, giving antibiotics for viral infection is a big no-no. And one of the most abused situations in medicine is where people give antibiotics for mostly upper respiratory tract infections such as sore throats, 90% of which are caused by viruses. But of course, we are not responsible for that. But for you, it is good to know as a healthcare personnel that this should be avoided. And if anybody is taking antibiotics for these upper respiratory viral infection, you should say that's a big no-no. So the second D is a drug. It's prescribing the drug of choice as per the local antimicrobial guidelines. And as I said earlier, each jurisdiction has their local antimicrobial guidelines. Hong Kong has its own guidelines, as well as in other parts of the world. US has other guidelines, and so on and so forth. So you have to be aware of these guidelines in your own area. The third is the dose. Prescribing the correct dose is important, because Underdosing will lead to emergence of resistant pathogens. So, and overdosing leads to possible toxic events and therefore wastage of course, wastage of antimicrobials. And so this is very, very important because low concentrations will lead to the so-called resistant organisms arising due to because they are not killed outright, but therefore these mutant organisms might arise, and as a result, you can get resistance organism developing and then spreading around. So that is the third D, diagnosis, drug, and the dose. The fourth one is the duration. So earlier there is so the shorter duration lead to emergence of resistant pathogens and prolongation of the illness. Also, unnecessarily long duration leads to possible toxic events, and that also can create a situation where the pathogens can actually get accustomed to the antibiotic, and then you get resistant organisms emerging. So shorter duration is important. But having said that, the current thinking is that that the antibiotic should be stopped as soon as the acute symptoms are over. The usual prescription of 5 days of antibiotics, and we used to say that please complete the course of 5 days or whatever number of days of the specific antibiotics. But the current thinking by the British Medical Association is that when the symptoms are over, the antibiotic should be stopped, because the body defenses have taken over, and they will then finish the organisms and complete the the abeyance of the situation. So this is the fourth one, the fourth D. The fifth D is de-escalation. So that means reduction in the spectrum of administered antibiotics through the discontinuation of antibiotics, or switching to an agent with a narrower spectrum. Sometimes you can start with the broad spectrum and knowing which organism caused antibiotics, you can narrow the spectrum. So this is the fourth D. And the final D is the debridement and drainage. And this should be undertaken by if there is a collection of pus or other necrotic material prior to antibiotic therapy, particularly if there are traumatic injuries. So it's the antibiotic does not reach the dead tissues. So it's important that the dead tissues do not act as a focus of further sort of growth of organisms. And therefore, that is the reason why we had to debridge a wound properly before or drain the antibiotic abscess, the dentoalveolar abscesses before giving antibiotic therapy. So as you can see here, so this is easy to remember: diagnosis, drug, dose, duration, de-escalation, debridement, and this is the so-called 6 Ds of antibiotic stewardships. And also there is another important component of the stewardship, which is the patient education, which is a part and parcel of antibiotic stewardships, because without the buy-in of the patients, we cannot actually, we can't force people to take antibiotics, or for that matter, any drug, because we have to respect their choice as well as our choice, or for that matter. So it's very important that you teach the importance of why you are giving a specific drug to a patient, so that he or she understands the rationale behind your prescription, rather than just blind therapy, or just the patient saying, okay, I got it last time and became well, so I want it back again. So this kind of situation could be avoided by patient education. So according to some of the guides, which this is from Hong Kong guide, antibiotic stewardship benefits include improved patient outcomes, reduces adverse reactions, minimal impact on subsequent antibiotic resistance, and of course, optimization of resource utilization. So this is when you look at the financial aspects, the healthcare aspects, the patient aspects, all benefit from our antibiotic stewardship, the way we look at it, So, so it is one of the core components of infection control. Um, Ideally, it has to be multidisciplinary, programmatic, and prospective. And the so-called, if you are having regional organizations, it should be the antibiotic stewardship program should comprise clinical microbiologists, physicians, infection control physicians, and nurses and pharmacists, and also dental practitioners. At the current time, they are not included at in Hong Kong, but I believe in USA they are included. So I'm going to just give you some tips on use of antibiotics in outpatient settings. Whenever appropriate, prescribe the simplest regime and shortest duration. And also they say take antibiotic timeout if possible, reassessing the need for antibiotics after 48 to 78 hours. And advise patient to observe the precautions while taking antibiotics. These are the precautions: frequent hand hygiene, eating or cooking, drink only thoroughly cooked boiled items, disinfection in covering all wounds, wear if mask if he or she has respiratory symptoms, and young children with symptoms of infection should be minimize contact with other children. So these are sort of additional things which have been brought to the focus in terms of antibiotic stewardships. So finally, I'm coming on to the antibiotic guidelines for implementing antibiotic stewardships in dental industry, and these are the American Dental Association guidelines, and this is actually very well prescribed in American Dental Association. So and I'm not going to go into detail because it actually, these guidelines are what I have outlined earlier in my presentation. So you can see that in America, in USA, 81% of antibiotic prophylaxis in dentistry was unnecessary. Yeah, so this is just a sort of one of the important points one has to realize, that most of the times when we give antibiotics, we have to think twice, because we may be abusing antibiotics, and we have to think of antibiotic stewardship principles. And so there are a number of steps again according to the ADA guidelines for dentistry, commitments, action for policy and practice, tracking and reporting, education and expertise. But these are details which I don't want to bore you with. So these are the details of antibiotic stewardships. There are nice guidelines. This is a ADA article on antibiotic stewardships. And so ladies and gentlemen, I would like to just conclude what the ADA has said in regards to antibiotics and green antibiotic therapy. Dentists, this is the American guideline, American numbers. 10% in UK is about 12% of our total antibiotic prescribed by dentists, and they found that between these 4 years, 2011 to 2015, 81% of antibiotic prophylaxis dentistry was totally unnecessary. And therefore, the ADA guidelines implore that dentists need tools to effectively implement stewardship initiatives in practice. And they are focusing on evidence-based clinical practice, appropriate messaging for patients and clinicians. So patients are very, very important in this. And the shared decision making, this is what I said earlier, when you give an antibiotic, you'll have to tell the patient why you are giving this antibiotic and the reasons for it, and so that the patient comprehends the why he or she is taking that antibiotic. At the end of the day, he or she is the person who is taking the antibiotic. So better coordination with other health professionals. So I would like to thank you for listening, and I just want to tell that the green. This is kind of the green principles behind antibiotic therapy, and we have to be in summarizing aware of the one health principle, where we in the ecosystem of the world, we are all one ecosystem, and if somebody abuses abuses antibiotic, then it goes back to yeah situation. So thank you very much for that presentation.